Is there a big difference in how you approach ATK versus BTK? You have those huge chunky calcifications in your, distal fem pop, say, adductor canal, are going into the pop near the level of the knee joint. What are you doing? Is your first thought heavy calcifications? Is your first thought shockwave? Is your first thought atherectomy? Jay, what goes through your head and what's your algorithm?
Yeah, I mean, for really bulky calcium, I've moved away from atherectomy using more IVL, and I found that works, especially the combination of IVL plus a specialty balloon seems to work really well for me. I mean, there are cases where I will use tools like CSI and whatnot to orbital atherectomy, even rarely a rotational atherectomy as well too for severe calcium above the knee. But the only problem is sometimes some of those technologies bounce off the calcium. So I do like IVL for that, for those kind of nodular lesions. And especially we have some newer IVL tools coming out. It's a whole bunch of stuff coming, which is really exciting. BTK, the calcium distribution is a little bit different than what we see ATK. A lot of times you need more circumferential, more medial calcification and whatnot too. I do some IVL for that, but I tend to use more specialty balloons. And a lot of times if it's hybrid type stuff, I might even use a combination of laser as well too. But most of the time I'm using a specialty balloon in those kind of situations for the BTK disease.
Okay. Michael, what about you? I mean, I would say for shockwave has definitely been a big game changer for us for ATK in my practice. Is that similar to you?
Yeah, I think that the biggest consideration I have when I'm dealing with real eccentric, boulder calcific disease of the SFA is like, I just got to get across. I think above the knee, because we have things like shockwave, because you have the ability to take really high pressure balloons to get luminal gain there, and then you have the bailout of fantastic drug-eluting technologies and implants, I think that it's easy to be really aggressive in that space. And I'd love to be true lumen in the ATK space every single time. But, when you're dealing with bulky stuff, it's sometimes hard to do. Shockwave has gotten so popular, and I use it all the time because I think I don't feel nervous taking a shockwave balloon to 4, 6, sometimes 8 atmospheres. Whereas if I'm taking a conventional balloon to 14, 16 past burst, sometimes that's harrowing.
And also and then compared to atherectomy too, I mean, the risk of embolization, it's just less on your mind.
Using atherectomy in a subintimal space, sometimes it's safe, sometimes it might not be.
Anything you do particularly, you mentioned, crossing true lumen, do you do any techniques or tips, in the ATK space to try to be true lumen? Mike, or just wire and seeing how the wire feels?
Fadi Saab and Jihad Mustafa and the C-top classification is something that I think about. So if a cap morphology isn't favorable and I've taken a bunch of different obliquities and I can't sort of elucidate that proximal cap very clearly, I'm super quick to just get retrograde access. Additionally, sometimes, I have to say this, I'm a surgeon, that there are situations where I think about doing a bypass.
Oh my, what?
Yes.
What?
Yes.
No.
It happens.
Yes.
And I promise you, there's situations where, maybe 3-4 years ago, I wouldn't have thought about bypass. And, I've sort of kicked myself because you have a dissection at your reentry. And now what could have been maybe a fem above knee pop or a fem BK pop is now a fem tib. And, maybe the vein is marginal now. Now I'm like, oh, I got to put PTFE there. That was a mistake. I shouldn't have done that. But I mean, sometimes the wire does what the wire wants it to do.
Sure.
Despite our best efforts. I don't have the time to pull a wire back with IVUS and go in and go out and but Jay has a lot of.
We can't be all like Jay. We can't be all like, he's pulling out OCT and all this stuff to getting true lumen.
Yeah, I mean, we did that for a long time. I remember back in the days of Avenger and the Ocelot and the Kitty Cat and things like that. We had all these front-facing imaging things. I mean, it was really a cool concept to try to stay intraluminal with imaging plus with crossing, but it never really took off, right? So a lot of what we do is by feel. And, you feel the cap. And then, I'm old school. I tend to do a lot of larger wires like the 035 Glabwire Vantage. And I use a lot of reflow specs catheters really kind of help me get across these lesions. And most of the time I do fine. And I have a very low threshold like Mike to go from the foot. I mean, honestly, if after a couple minutes, I'm not crossing from above, I'm going retro as well. I mean, I'll even, porate a lesion from the outside if I have to, like we use a kind of a pierce technique and whatnot. So I don't have his luxury of sending me for surgery. But again, we have to be cognizant of what we do so that we don't burn bridges and don't allow the patient potentially get the right type of operation ultimately done if that's what's necessary.
Totally agree. I mean, it's pretty universal for people who do a lot of endovascular work is that everyone will say they go, retrograde, they go pedal pretty quickly. And I think it's pretty old school thought now that try so long from above, or if you're doing that, then you're doing something wrong.